So, dear students, good day, nice to meet you. So, today's lecture will be about anatomy of genital or reproductive system. On today's lecture we will talk about briefly anatomy, physiology of male and female reproductive system, and mainly concentrate attention on applied moments of anatomy of this system. Many clinical issues I'll be explaining based on anatomical knowledges. But firstly, what's function of reproductive system? Actually, reproductive system or genital, as I said above, it is formed by organs involved in sexual reproduction. And firstly, we will talk about male reproductive system. Actually, all organs of male reproductive system or male genital organs can be subdivided into two groups: internal organs and external organs. Let's go through them, let's name them. So, internal organs: testes, found in scrotum. Also, you have to know two more names of this organ: didymis and Greek name orchis. Why it is important for you? Because many clinical medical terms come from Greek word orchis. For example, inflammation of testes is known as orchitis. Next organ, epididymis, which is attached to posterior border of testis. Next organ is ductus deferens, very long tube which conveys sperm. Sometimes it is known vas deferens. You can use both terms, ductus deferens or vas deferens. Next organ is ductus ejaculatorius, ejaculatory duct. Next one is seminal vesicles or seminal gland. Next one is prostate, prostata or prostate gland, and bulbourethral glands, also known as Cowper's gland. Cowper's is eponym. It is named in honor of scientists who firstly described this organ. And two external organs. First one is scrotum, sac containing testis, epididymis and initial part of vas deferens, and penis. And let's go briefly through all these organs. First organs, testis and epididymis. In details you will consider structure of these organs on practical class. Now I'll just briefly revise. So, testis, it has anterior and posterior borders, superior and inferior poles, and two surfaces, lateral and medial surface. How to differentiate them if you have only one testis in your hands? Pay attention to the red arrow. It indicates so-called epididymis sinus, sinus epididymidis. Epididymis attaches to posterior border of testis, but not completely, except this area facing laterally. So, that side where you see this like a pocket sinus, it means it is lateral surface. If to go inside of testis, we can see that testis is divided by septa into lobules, and these lobules contain so-called seminiferous tubules. And actually there are two types of seminiferous tubules. You see some of them coiled and some of them not coiled, straight. So they are known as convoluted seminiferous tubules or tubuli seminiferi contorti, and straight seminiferous tubules or tubuli seminiferi recti. Actually, I'm sure you know that function of testis is secretion. It is considered as mixed gland. Mixed, I think you know that those glands which have both exocrine and endocrine parts. As exocrine organ, testis secretes sperm. As endocrine organ, it releases sex hormones, generally named androgens. So now we will concentrate attention on exocrine function, so secretion of sperm. It takes place in convoluted seminiferous tubules. After that, sperm goes through straight seminiferous tubules and join so-called like a network of tubules known as rete testis. Rete testis. Then from rete testis efferent ductus originate, which empties into epididymis, but especially its epididymis duct. So epididymis has three parts: head, caput epididymidis, body, corpus epididymidis, and tail. And inside epididymis has ductus epididymidis, which gets sperm from efferent ductus. And after that, duct of epididymis, after its tail, continues as vas of ductus deferens. Some clinical issues related to the testis. Look, you know that in adults' body testes are found in scrotum, but in fetal life primordium of testis appears very far from scrotum. Let's see this picture. What we can see here? Here we can see kidney, that is future suprarenal gland, and look, above kidney at the posterior abdominal wall there is primordium of testis. And at the 5th week of prenatal life, testis starts to descend. It goes down and it passes through anterior abdominal wall to form inguinal canal. And just at the birth time, testis should be in scrotum. So general idea that testis appears initially at the posterior abdominal wall in the lumbar region near kidney, above kidney, and then step by step it descends, passes through inguinal canal and appears in scrotum. That is normal development of testis, but some clinical cases happens known as undescended testis, or scientifically cryptorchidism. Cryptos unknown, orchid, as I said above, it is Greek name of testis. Look, you see here this picture shows some types of cryptorchidism. Look, normal position when testis is found in scrotum, but sometimes it stops in abdominal cavity, so it is abdominal type. When it passes through inguinal canal and stops here, it is inguinal type. Or when it exits inguinal canal but stops at the upper part of scrotum, it is known as prescrotal or prepubic type. So after epididymis, sperm goes through ductus or vas deferens. It is very long tube. Look at this picture. You see it starts from the tail of epididymis and then it goes up and terminates behind bladder. Now we will consider its topography in more details. So actually, deferent duct has four parts: testicular part, funicular part, inguinal part, and pelvic part. So, testicular part, when vas deferens has relation to testis. After that, it joins structure called spermatic cord, in Latin funiculus spermaticus. So when it passes as component of spermatic cord, this segment is known as spermatic part. Let me show you. Here you see at this picture that is spermatic cord which contains ductus deferens. So this part of ductus deferens is spermatic or funicular part, and this cord passes through inguinal canal together with vas deferens. So its segment passing through inguinal canal known as inguinal part. It is here. And after that, when it exits deep inguinal ring, look, it is present here. After deep inguinal ring, here is ductus deferens. It goes towards urinary bladder. Look, it is posterior view of urinary bladder. Here is vas deferens. Here, don't confuse please, here is ureter, which carries urine towards urinary bladder. Here seminal vesicles and prostate gland. So ductus deferens, its terminal part, as you can see, dilated and named ampulla of ductus deferens. This ampulla joins excretory duct of seminal vesicles to form ejaculatory duct, but about this a bit later. So come again please about parts of vas deferens. It starts from tail of epididymis, relates to testis, so initial part named testicular. After that it goes as a component of spermatic cord, funiculus spermaticus, so funicular part. Next passes through inguinal canal, inguinal part. After deep inguinal ring, vas deferens goes in pelvic cavity, so pelvic part. And its terminal part dilated called ampulla, joins excretory duct of seminal vesicles. And some clinical issues. You see, this tube is very long, and actually this duct can be a way of spreading of infection. You see, it terminates at the area of urinary bladder, seminal vesicles, prostate gland. So actually infection may track from bladder and urethra along vas deferens towards epididymis to cause it acute inflammation, acute epididymitis. So it is possible due to this topographical relation. One more thing, we said that function of vas deferens is conduction of sperm from epididymis towards male urethra. And actually this anatomical feature and physiological feature can be used in surgery for male sterilization. Actually this procedure is known as vasectomy. If to say simply, you see, it is a cutting of both vas deferences. Of course, if both deferent duct were cut, sperm can't pass through this like a blockage. So finally, such males are sterile due to this issue. And on this slide you can see many related information to this manipulation. One more clinical thing. I mentioned that vas deferens passes through inguinal canal. And I am sure you know that very common problem related to inguinal canal is inguinal hernia. Hernia is abnormal protrusion of abdominal content through natural openings. Look here, that is a part of intestine, and it passes through inguinal canal and appears after superficial inguinal ring absolutely abnormally. So this case is a herniation, protrusion of abdominal, no, in this case intestine, through inguinal canal to superficial inguinal ring. And of course, such disease cannot be treated therapeutically, only surgically. So surgeon must make herniotomy, section of hernial sac and plastics of these structures. And how it relates to what we are talking about. You see that one of the structures passing through inguinal canal is ductus deferens. So while herniotomy, surgeon must keep in mind presence of ductus deferens and be very careful here to avoid damage of vas deferens suddenly, because it might cause sterilization. And let me comment one term posted on this slide, iatrogenic. Iatrogenic comes from Greek word iatros. Iatros means doctor, physician. Genesis, no, genic, genesis, origin. So iatrogenic, this term means when problem caused by actions of medical official, doctors, nurses, and so on. Next, funiculus spermaticus or spermatic cord. Actually, it is not really organ, so I did not list it when we talk about male genital organs. It is a combination of structures involved in reproduction as well. So, what are the basic components? No, one of them we mentioned many times, ductus deferens or vas deferens, basic component of spermatic cord. And this deferent duct is accompanied by artery, testicular artery, artery of vas deferens, testicular vein, and veins actually form venous plexus. This plexus is known as plexus pampiniformis. Keep in your mind, venous plexus of spermatic cord, plexus pampiniformis. And besides that, all the structures are covered by coverings, shells of spermatic cord, which corresponds to the tunics of scrotum. They are similar to scrotum, besides skin. And let me show these mentioned structures on 3D module. So what we can see here, that is urinary bladder, below to it prostate gland, through which urethra passes. Then on the posterior wall of urinary bladder we see seminal vesicles with excretory duct, then ductus deferens with its ampulla, and ureters. Ureters empty into urinary bladder. So that is, look, pelvic part of vas deferens, its terminal dilated part called ampulla. You see it joins excretory duct of seminal vesicles to form ejaculatory duct, ductus ejaculatorius, which passes through the substance of prostate gland and opens to male urethra. Besides that structures, what else we can see here? Look, here is spongy urethra, corpus spongiosum, its terminal part, posterior part called bulb. And here we see derivatives of corpora cavernosa, roots of penis. And this small structure is bulbourethral gland, which opens into urethra in bulb of penis. So next, accessory glands of male genital system involves two major glands, prostate gland and seminal vesicles. Prostate gland was named by old anatomists as second heart of man. Why so? Because actually, what's the case? Spermatozoa secreted by testes are not able to fertilize because they are not mobile yet. They are able to fertilize egg only after they become motile. And this happens when sperm mixes with secretion of prostate gland. It is known as prostatic juice. Only after that they become active and able to fertilize oocyte. So due to this issue, it is known as second heart of man. So prostate gland, briefly, a few words about its topography. Maintain that it lies below to urinary bladder and it is penetrated by male urethra. Besides that, also ejaculatory duct passes through prostate gland. And prostate gland has on section two parts. First one, glandular part, because it is gland, exocrine gland, it provides secretion of prostatic juice, so it has glandular part. And another part is muscular, which acts as a sphincter of male urethra. And seminal vesicles, paired organ found on the posterior side of urinary bladder and in front of rectum. Let me pay your attention to this topographical relation that seminal vesicles and prostate gland lies in front of rectum. Later I'll explain you clinical significance of this anatomical relation. And seminal vesicles is also exocrine gland. It secretes liquid component of semen rich in fructose, which provides energy for sperm. And one more thing regarding internal structure of prostate gland. On section in male urethra, on the posterior wall of prostatic urethra, we can see bulging like elevation called colliculus seminalis, seminal colliculus, which has many openings for excretory ductules of glandular part of prostate gland and also for ejaculatory duct. And some clinical thing related to what I said above. So actually prostate gland and seminal vesicles, due to anatomical topographical relation with rectum, can be palpated by rectal examination. Look at this left picture. You see doctor inserts finger to rectum and through very soft anterior wall of rectum he can feel and palpate prostate gland and seminal vesicles. Normally, surface of prostate gland is smooth. So, if doctor feels by finger that it is rough, or some bulgings, elevations, or something else, it means something goes wrong with prostate gland and it requires more precise attention, diagnostic. This rectal examination can be used for diagnostics of conditions of prostate gland and seminal vesicles, and also can be used as method of treatment. It is known as prostatic massage. It can be used, procedure is absolutely same, actually massaging of prostate gland through rectum. That is nature of this procedure. And it can be used in case of benign prostatic hyperplasia or chronic prostatitis, not acute prostatitis, but chronic prostatitis. And also a very common problem with prostate gland in elderly men is enlarged prostate gland. Why it is very important to know this issue? I said that male urethra passes through prostate gland. And when prostate gland enlarges, it blocks passage of urine, compressing of urethra. And of course, this condition is very dangerous because urine should be discharged from urine bladder permanently. It secretes regularly, so it must be removed from our body. If there is a blockage at the level of prostate gland, it will be accumulated in urinary bladder, but it cannot be unlimited volume of bladder, maximum 1 liter. If do not remove urine from urinary bladder, it can rupture with very serious problems as peritonitis. And one more time about seminal vesicles. You see, it is if it is exocrine gland, it has excretory duct. This duct joins terminal segment of ductus deferens to form ductus ejaculatorius, which opens to the male urethra. And some biochemical features of secretion of seminal vesicles can be used in forensic medicine, as it is described here. Secretion of seminal vesicles rich in fructose. So if fructose provides a forensic determination for occurrence of rape, whereas choline crystals provide the basis for determination of the presence of semen, so-called Florence test. And male urethra. Usually we consider it together with male genital system, but male urethra as against female urethra belongs to both urinary system and genital system. Why so? It is because male urethra conveys not only urine but also semen with sperm, so it can join both urinary system and genital system. Few words about it. Actually, male urethra starts from neck of urinary bladder by internal urethral orifice, then it passes through prostate gland, and this part of urethra known as prostatic urethra. It is mentioned here at the right side, prostatic urethra. In some anatomy textbooks, part prior to prostatic urethra, very short, known as pre-prostatic urethra, but many authors do not describe it. So after that, male urethra passes through perineal membrane or urogenital diaphragm, so it is known as membranous urethra, or sometimes named intermediate urethra. And after that, longest part of urethra goes through spongy body of penis, so it is known as spongy urethra or penile urethra, which opens at the glans penis by external urethral orifice. It is narrowest place of urethra. Actually, male urethra has some constrictions and dilations. You will consider them on practical class. I'm paying attention only that narrowest place is external urethral orifice, and before it there is a large dilation of male urethra known as navicular fossa, fossa navicularis. And now let's summarize our knowledge about secretion and pathway of sperm. This animation describes it. So you see sperm appears in testes, convoluted seminiferous tubules, then straight one, efferent ductules. Bolus moves too fast, see it, and then I'll explain slowly without this ball. So sperm appears in convoluted seminiferous tubules of testes, then it goes through straight seminiferous tubules, tubuli seminiferi recti, after that rete testis, then efferent ductules, ductuli efferentes testis, which opens into duct of epididymis, which continues as ductus deferens or vas deferens with 4 parts. Then ductus deferens, its terminal dilated part ampulla, joins excretory duct of seminal vesicles to form ejaculatory duct, and ejaculatory duct opens to prostatic urethra. Male urethra, especially prostatic part. And one clinical issue related to male urethra and urinary bladder is bladder catheterization. I'll not mention everything posted here. You will read it like a prescription. When do we need to perform bladder catheterization? But most common problem, which I mentioned, hyperplasia of prostate gland, which blocks outflow of urine. So in this case we should help the patient, and this a catheter, it is a special tube, inserts into external urethral orifice into male urethra and moves along it very slowly and carefully, and passes through this blockage and enters into urinary bladder to remove urine from urinary bladder. And last internal male genital organ is paired bulbourethral glands or Cowper's glands. They are seen here. Actually, these glands were named in honor of British anatomist William Cowper. He is considered as, he is credited to be first who described them, but some historians of medicine gives information that French surgeon and anatomist Jean Marie described them some years before. No, he really mentioned of them, but he did not provide comprehensive description of these glands. But in 1699, William Cowper released like an article where he described bulbourethral glands not only in humans but also in many mammals, and he provided first illustration of these glands. So really this picture is the first illustrations of bulbourethral gland in history of medicine. These glands are exocrine, and their secretion opens into urethra, where it moves through bulb of penis, and its secretion lubricates surface of male urethra to lighten passage of semen. Few words about external genital organs. We will not spend much time on scrotum. Few words. I advise you to use this diagram when you will prepare your home task for practical class. This diagram shows derivatives of scrotum, how its layers derive from anterior abdominal wall. Actually, mechanism of appearance of scrotum, passage of testis through anterior abdominal wall, and it pulls all these layers. So actually there are 7 uniques of scrotum, and each of them corresponds to particular layer of anterior abdominal wall. When you will prepare home task, see them distinctly using this picture. You have to know what is tunica dartos, how it derives, what is its equivalent in anterior abdominal wall, external spermatic fascia, cremasteric muscle, internal spermatic fascia, vaginal tunic, and so on. One applied moment of scrotum, why it is too important. Actually, as we said, scrotum lodges testis, where spermatogenesis takes place. And spermatogenesis should go in constant temperature. So it means some surrounding structures in scrotum must maintain temperature in testis, and it is done by mechanism described on this slide. Actually, there are two muscles, cremasteric muscle and dartos muscle. One of them is skeletal, another one is smooth muscles, and when they contract, they either pull testis closer to superficial inguinal ring, which has links with abdominal cavity to be warm, or away from superficial inguinal ring in hot conditions. One more external male genital organ is penis. Internally it consists of 3 structures: unpaired spongy body, corpus spongiosum, and paired cavernous bodies, corpora cavernosa. They are different in structure, and on section you can see that corpora cavernosa is formed by specific tissue rich in vessels, and in erect conditions these caverns, like spaces, are filled with blood, and penis changes its position. So what parts can we distinguish in penis? Glans penis, body of penis, and root of penis. Glans penis derives from corpus spongiosum. Besides that, one more derivative of corpus spongiosum is its posterior dilation, called bulb of penis, which gets secretion from Cowper's gland. And the derivatives of corpora cavernosa are crura penis, which form radix of penis. Next part of our lecture is about female reproductive system. So actually, similar to male genital system, female reproductive organs can be subdivided into 2 types as well. They are internal and external organs. So let's name internal ones. They are ovary, uterine tube, uterus, and vagina. and many external female genital organs. They are mons pubis, labia majora, labia minora, hymen, clitoris. Then also we can see bulb of vestibule, greater and lesser vestibular glands. All of them are external female genital organs. And let's go through them briefly. On real specimen, previous picture was artificial, here is cadaveric material. Let's find what we can see here. That is ovary with uterine tube, they are not seen distinctly here. Then here we can see uterus, this is vagina. Here is urethra, labia majora. Behind vagina and uterus is rectum. And here we can see very deep pouch known as Douglas pouch or recto-uterine pouch, excavatio recto-uterina. Keep in your mind, later I'll explain you its clinical significance of this space. And real picture from vital contents of pelvic cavity. Here we see uterus, then uterine tubes, ovary, and behind uterus there is Douglas pouch, excavatio recto-uterina. Then one more thing. Let's go through basic things of internal genitalia. First of all, you have to know many additional names of these organs. So, ovary, Latin name of this organ is ovarium, but you have to know one more name, Greek one, oophoron. And actually, inflammation of ovary is known as oophoritis. Next organ, uterine tube. Very often you name it fallopian tube. You can do it, it is not mistake, but fallopian tube is not official name of this organ. It is eponym name in honor of Gabriele Fallopio, Italian anatomist and surgeon, who firstly compared this organ with music tube, and he provided name for it as tube, but according to Terminologia Anatomica, this organ known as uterine tube. In Latin, tuba uterina. But you have to know also its Greek name, salpinx. Salpinx. And very common ovary and uterine tube inflamed together, and in this case we talk about salpingo-oophoritis. Inflammation of uterine tube and ovary, or instead of salpingo-oophoritis we can use term adnexitis, because as I posted below, ovary and uterine tube together known as adnexa of uterus. So when they inflame together we can name this condition adnexitis. As for uterus, actually English name is, it is not official, not anatomical name, womb, but in anatomy we have to name it uterus. Latin name uterus. Besides that, you have to know two more names of this organ, metra and hystera. Some terms, both anatomical and clinical, come from these two words. I am sure you know that uterine wall has three layers: endometrium, myometrium and perimetrium. So you see this term named using word metra. Also parametrium is present. It is not layer of wall, it is adipose tissue surrounding cervix of uterus. And hystera term is also acceptable in gynecology there is such operation known as hysterectomy, removal of uterus. You see, it comes from not from uterus matter but from hyster. And vagina, one more internal genital organ. Be attentive, sometimes students mistakenly name it as external genital organ. Not, it is not true. Vagina is internal genital organ, Latin name vagina, and you have to know Greek name kolpos. Kolpos, and inflammation of mucosa of vagina known very often colpitis, or method of investigation, assessment of mucosa of vagina known as colposcopy. Colposcopy. So, briefly about internal female genital organs. So, ovary, it is typical gland of mixed type, similar to testis. It was also mixed gland. So, ovary has exocrine part, endocrine part. Exocrine part involved in secretion, production of oocyte, female gamete, and endocrine function means secretion of hormones, female sex hormones like estrogens and progesterone, main hormone of pregnancy. I won't spend time to explain anatomical structure, it is material of practical class. I would like to concentrate attention on one physiological mechanism. So, I am sure you know that one action in menstrual cycle is ovulation. Ovulation is release of oocyte from follicle in ovary. It takes place one time per 1 month. One very interesting anatomical feature why it is possible. Actually, ovary is not covered by peritoneum. It is covered by very thin layer of germinal epithelium, and it is very thin, and it allows oocyte to pass through it. So, come again, every month oocyte is released from ruptured follicle, and this oocyte enters abdominal cavity. Actually, it lies on the surface of ovary. And you have to know that oocyte is unmovable cell. It has no any devices for motions. So, but you know that significance of oocyte is fertilization by sperm. Normally, fertilization occurs in uterine tube in its ampulla part. Uterine tube has some part. Distal one is infundibulum with fimbria, like a finger-like projections which are movable and looking for oocyte. So next to infundibulum is ampulla, then narrow part called isthmus, and intramural part inside wall of uterus known as uterine part. So after rupture, oocyte found in abdominal cavity on surface of ovary. Very close there is a fimbria, and this fimbria catches oocyte and sends it to the cavity of uterine tube. But you see, first part is infundibulum, but it must travel towards ampulla. Oocyte is unmovable cell. So which factors help oocyte to move through uterine tube? Actually, there are two factors. First one, uterine tube, as any tubular organ, has four layers. Innermost of them is mucosa. And mucosa of uterine tube is lined with ciliated epithelium. So the cilia move towards cavity of uterus and they pushes oocyte towards cavity of uterus. One more factor helping in this process is presence of muscular tunic in uterine tube, which has two layers, longitudinal and circular, and contraction of this layer also helps oocyte to move through uterine tube. And after that you have to know what happens in ruptured follicle in two cases: when oocyte will be fertilized and when fertilization will not occur. So when oocyte travels throughout uterine tube and it meets no sperm, in ruptured follicle will be filled with connective tissue and becomes so-called corpus albicans. Corpus albicans, whitish body, direct translation into English. But when fertilization occurs in ampulla of uterine tube, this ruptured follicle transforms into yellow body, corpus luteum. Corpus luteum gravidarum, so yellow body of pregnancy. And this body starts to work as endocrine gland. It secretes progesterone, main hormone of pregnancy. And one more thing. We said that fertilization occurs in ampulla of uterine tube, and after fertilization appears new organism called zygote. It is also unmovable structure, and peristalsis of uterine tube and ciliated epithelium helps zygote to move towards uterus. And normally zygote attaches to the wall of uterus. This process is named as implantation. Usually it happens on 7th day of pregnancy. So implantation happens in the cavity of uterus. And then embryo will grow and later fetus will appear in growing uterus. Some words about uterus. First of all, topography. Look, uterus is found in pelvic cavity. In non-pregnant conditions, of course, when uterus is pregnant, it enlarges and reaches abdominal cavity. So in front of uterus there is urinary bladder behind rectum, and there are two pouches around uterus. In front of it vesicouterine pouch, and behind it rectouterine pouch or Douglas pouch. And as you can see, position of uterus in pelvis is not straight. We describe its position as anteversion and anteflexion. How to understand anteversion, anteflexion? Look, actually anteversion, it is an angulation between long axis of cervix. Uterus has such parts: fundus, part of uterus above attachment of uterine tube, then body, and cervix. Sometimes some textbooks describe narrow part between body and cervix as isthmus. So, long axis of cervix, this one, red one, long axis of cervix and long axis of vagina, you see they make right angle 90 degree. So it is facing forward, anteversion. Anteflexion, we should take into account long axis of cervix, red one, and long axis of body, green one. This angle is about 120-170 degree. It is normal position of uterus, anteversion and anteflexion. And I would like to concentrate attention on clinical things. So first, one very common problem, infections on female genital tract. First of all, there is one feature of female organism that abdominal cavity of females is not closed sac. It has communications with external environment by means of presence of a uterine tube with abdominal openings and cavities in it, in uterus and in vagina. So, very often infection from external environment might reach peritoneal cavity to call pelvioperitonitis. Pelvioperitonitis, it means inflammation of peritoneum in pelvic cavity. Or step by step it might cause firstly salpingitis, inflammation of mucosa of salpinx or uterine tube. Then one more very common method of assessment of female reproductive tract, especially for patency of uterine tubes. It is known as hysterosalpingography. Remember, I provided you other names of female genital organs. Hystero means related to uterus, salpingo related to uterine tube, grapho recording. So actually, hysterosalpingography is method of X-ray examination. How it is done? Look, what we see here. Actually, radiopaque substance injected into canalis cervicalis. You see, it fills cavity of uterus. Then it spreads via uterine tube and it discharges into peritoneal cavity, because uterine tube normally has one opening facing towards uterus, another one leading into abdominal cavity. So here on this picture you see normal picture of female reproductive tract. Cavity of uterus filled with this dye, tubes filled, and it is discharged to abdominal cavity. You see shape of uterine cavity is normal, both tubes are patent. But here on these pictures you can see pathology. For example, here bilateral tubal blockage, here blockage of radiopaque substance, and here we can see hydrosalpinx. Hydro means fluid, accumulation of fluid in dilated salpinx. Or here you see very interesting case, bicornuate uterus. Actually it is congenital anomaly. In some mammals, in many mammals, uterus is multicornuate, but in humans not. It is has no any horns. It has shape of cavity like triangle, but here you see really two horns. It is bicornuate uterus, but it is anomaly. Then one more very common problem with female reproductive tract is ectopic tubal pregnancy. Ectopic pregnancy. Normally, remember I said that fertilization happens in ampulla of uterine tube, but normally zygote travels via uterine tube towards uterus, and usually at the upper corner of uterus, right or left, implantation must happen. It is typical situation, normal situation. But sometimes due to different issues, chronic inflammation and so on, implantation can take place ectopically. Ectopy means not in normal place. For example, in cervix, it is not normal situation. Then in isthmus, or in the uterine tube, it is tubal pregnancy, or even in abdominal cavity. Very difficult issue in case of uterine tubal pregnancy. Why so? Of course, as zygote grows, it becomes larger, and finally it might cause a rupture of uterine tube with severe bleeding. That is a complication of this process. Some more things related to clinical significance of this topic. We described normal position of uterus in pelvic cavity, anteflexion, anteversion, but this diagram demonstrates pathological positions of uterus, and one more thing known as prolapse, when due to relaxation of ligaments, weakening of urogenital diaphragm, uterus goes down and passes through vagina and appears even visible outside. It is named prolapse of uterus. Here on this picture you can read regarding relaxation. Actually, uterus is fixed in pelvic cavity by means of some ligaments. Most important of them, broad ligament, ligamentum latum, which is derivative of peritoneum, then uterosacral ligaments, cardinal ligaments, and ligamentum teres uteri, round ligament of uterus. Of course, during pregnancy they stretch, and if they not return to normal conditions after pregnancy, they are weakened, relaxate, and it might cause finally prolapse of uterus. One more thing, vaginal fistula. Fistula is abnormal channel in our body. And actually, due to topography, vagina has relation to all surrounding structures like urinary bladder, urethra, which is found in front of it, or rectum, which lies behind of it. And sometimes due to complicated labor or something else, there's abnormal communications appear. They are known as fistula. And they can be rectovaginal fistula, when there is a abnormal communication between rectum and vagina appears. Of course, in this case, contents of rectum can move to vagina, or a vesicovaginal fistula or uretrovaginal fistula. In this case, urine will be discharged not only to external environment via external urethral orifice, but also will be leaking into cavity of vagina. And one more manipulation, very common related to today's topic, known as caldocentesis. Let me firstly explain you what it means. Actually, synthesis means like a puncture. Caldo comes from French what cul de sac, which is known in English as bottom of sac. Which sac means? Actually, it is abdominal cavity with peritoneum which resembles sac. And bottom of sac means lowest its portion, which I mentioned many times today. It is vesicouterine pouch and rectouterine pouch. So actually rectouterine pouch is known as Douglas pouch. It is lowest and deepest part of abdominal cavity. Why I am paying attention to this? Lowest and deepest. It means that if any fluid, pathological fluid is found in abdominal cavity, especially in pelvic cavity, most probably it will be accumulated here in rectouterine pouch. What cases it can be? For example, rupture of uterine tube in case of tubal pregnancy. It is any rupture accompanied with bleeding, and this blood will be accumulated most probably here in this pouch. And actually this pouch is located very close to space called posterior vaginal fornix. Let me comment, what is it? Actually, cervix of uterus inserts into cavity of vagina, and due to relation of vagina it has two parts: vaginal portion facing to vagina and supravaginal portion. Vaginal portion of uterus is embraced by walls of vagina, and there is a space between wall of vagina and wall of cervix, and this space is known as fornix of vagina. And due to topography we can distinguish its posterior part, anterior part of fornix, and two lateral parts, or simply posterior fornix, anterior fornix, and two lateral fornices. So, and actually how caldosynthesis is performed. Needle is inserted through posterior vaginal fornix into Douglas pouch, then aspirate, nurse or doctor aspirate contents of Douglas pouch, and we see it in syringe, and we can analyze. It is blood, so it means internal bleeding happens, or inflammatory fluid called exudate. It's another tactics of treatment happens. Thank you for your attention.